Good afternoon. This is the House Appropriations Committee. It is Tuesday, December 16th, 2025. We have had morning sessions and lunch, and now we are back to talk about the Budget Adjustment Act. And we are going to, this afternoon is Agency of Human Services Day. Afternoon. So we have the secretary, I believe, is on Zoom or will be. Yes. Hello, Secretary Samuelson. Sorry you're not feeling well. Glad you could join us. And Tracy, remind me your last name? O'Connell, who's the new CFO at AHS.
That's correct.
Letters. So welcome to both of you. We have any? Get some documents. Oh, okay. Okay, I will look for mine. And why don't you two introduce yourself for the record while I'm finding my piece of paper? There we go.
Good afternoon. I'm Jenny Samuelson. I'm the secretary. For the record, I'm the secretary for the Agency of Human Services. I apologize for not being able to be in person today, but I am following the guidance of our Commissioner of Health, who says when you're stay home. So
thank you for role modeling good behavior.
And for the record, I am Tracy O'Connell, and I am the Chief Financial Officer for the Agency of Human Services.
Both of you.
And so we have a PowerPoint overview of what our budget adjustment request looks like. And I believe Autumn is my colleague Sean on. Okay, so Sean Benham, my colleague at AHS, is going to share on the screen, but I think you also have it electronically and in handouts.
So again, good afternoon. We're going to start with a basic overview of the agency, and then we'll roll through with a little bit more detail what you can expect over the next couple of hours with the departments within the Agency of Human Services. So just as a reminder, the Agency of Human Services includes 6 departments, including Department for Aging and Independent Living, Department for Children and Families, Department for Corrections, Health Access, and the Department for Mental Health. As we go through the budget today, we're going to give you a broad breadth overview of what you're going to see in BAA for each of the 6 departments and the central office. And the central office includes healthcare reform, along with some of the detailed categories where we are seeing some major changes. As a reminder, the Agency of Human Services budget for fiscal year 26 was $5.8 billion across all fund sources, with about $1.4 billion of that in general fund. The budget adjustment that we're going to present today includes a total of $33.2 million of general fund plus some additional one-time funds. So what we've seen in major changes since the last time we were here and presenting our budget are significant pressures in a few main categories. So you'll see budget pressures or budget ups to the tune of $49.5 million. These primarily fall in the area of caseload, where we're seeing an increase in the number of individuals who are coming onto our programs. Required rate adjustments, and those include both state and federal required rate adjustments for providers. Contractual agreements that we've had to renegotiate over the period since the budget was passed, and a smaller category of other general operating expenses. You'll also see that there are a couple of areas where we see savings and offsets. That includes $16.3 million, and that includes increased revenue and a decrease in caseload in some of our smaller programs. We'll present this across the entirety of the agency. The executive leadership team of the agency, which includes the commissioners of each of the 6 departments, plus the Medicaid director, the deputy director, the deputy secretary, and the secretary are presenting this budget on behalf of the agency. For that, I'm going to turn it over to Tracy for some of the more detailed specifics in each one of these categories where we see our pressures.
Great. Thank you, Secretary. So the first category where we're seeing pressures is in the caseload and utilization space. We are requesting $23.2 million of general fund to address this pressure. The main drivers of that are DIVA Medicaid consensus, as well as DIVA clawback. At DMH, we're seeing increased caseload and utilization at the private non-medical institution providers. DCF has seeing an increase in the sub-adoption space, as well as the general assisted support services, which includes burials, dentals, and abortions. In the Dale Choices for Care, we're seeing nursing home bed days, as well as home and community-based pressures. And then for the DOC out-of-state, there was an out-of-state trip on November 1st that sent 30 individuals to the out-of-state provider.
Well, I just have a sort of a broad question.
Sure.
We spent a lot of money on increased caseload and utilization last year. We had to do that in budget adjustment, right? And so we're doing it again this year. So I mean, I can see at one time, but we have this continuing upward trend of this. Do you have any thoughts about what's going on here?
I think, oh, go ahead, Jenny.
Go ahead, Jen.
No, that's okay. Again, please, Tracy, jump in here. What we've seen with the Medicaid program and the consensus forecast, that's been much more stable in terms of the overall caseload. But in this case, what we're seeing in the Medicaid program, at least, is a increase in overall utilization. So the cost per actual individual who is enrolled has increased significantly. Because we also have healthcare reform, we can see that that's consistent not just within Medicaid, but across multiple insurers. So I can't speak to the exactly what's driving that, but we are seeing significant increase in utilization. Tracy, if you want, I think you probably have something to add there.
I was also going to hit upon in the Choices for Care space. For the nursing home bed days, there were 3 providers that were experiencing a backlog in claims due to some transition of ownership. And so I believe that's $9 million gross, or about $4.5 million general fund. That was an expense for last year that carried forward into this year by the time claims were paid out.
But I'm interested in why we are having this increase in utilization. You know, so is the agency looking into trying to understand that better?
Yeah, when it comes to Medicaid, DIVA we can give them a heads up. If not today, another time, they can provide a little more of an overview and where they're seeing an increase in utilization. We are monitoring and tracking that closely, and DIVA, particularly for the Medicaid program, can provide more of an answer there.
Okay, thank you.
Can I just ask one follow-up question? I'm sorry. When we say utilization, are we talking about the number of visits, or I mean, it's so the use of Medicaid of the medical plan has increased. It's not the cost that has increased.
That's correct.
Okay.
That is correct.
Okay, Wayne, Lynn, Dave.
So the question then becomes, is it following the demographics, of the aging of the population? Is that, because what we're getting to, we're here for BAA again. These are one-time unanticipated things that you just can't predict. That's one thing. Other thing is if you have demographics that are shifting and that they, in a predictable way, then you could write it into your budget without having to appropriate.
Yeah. What do I want to know more about it?
Yeah.
Yeah, what I hear you saying is the number of people on Medicaid is not increasing. That's a stable number, but the intensity of their care, they're sicker than they require more care, the ones that are there. And maybe that hooks into the demographics. And that might also hook into your nursing home choices for care as well. They're just older, sicker, more utilization for the same number of people. Is that correct?
think that's what we're
I
gonna
don't
ask
I
Diva.
don't want to make any assumptions about the demographic issue here in terms of the older and sicker. Well, Diva can definitely come in and provide more information on where we're seeing utilization. That said, I do think that we are seeing more use in our nursing home, and that probably is more directly related to the demographic issue. But the broader Medicaid utilization, I would want Diva to come in with their numbers.
Thank you. Dave?
It may show up elsewhere in the presentation, but imagine if you had to explain these bullets to 150 people with varying degrees of understanding. If you could give us a couple of sentences, written at the sixth grade level, no, like what is clawback? Just that would be helpful. Somebody's, and I hate to make more work for people, but it would be helpful.
Yes,
Nolan?
Nolan with the Director's Office. I am part of the Medicaid consent group, and I also want to flag that it's not necessarily that utilization is up, it's that utilization came in higher than we projected. So it's just as much a measure of what we thought would happen versus what did happen. So it's not necessarily utilization reduction. I mean, it is, but it's just varied from what we thought it was going to be.
Right, so
So
relative
it's
to
really
the
a
projection.
projection and adjustment because we're trying to use a magic ball or a
Yeah.
snow globe to predict the future. And this just tells us how much we're right or wrong.
Right, and we've been kind of off the last 2 years
Yeah,
on utilization, so,
Because the trend is, the post-COVID trend, we still haven't figured out.
yeah.
It used to be we could look at a 10-year trend and figure it out, and now it's like the world is all over the place. So I just want to flag that it's not just utilization up per se, it's just up compared to what we thought it was going to be.
Our ability to predict has not been
So
so
there's a
good.
bit of that, so I just wanted to just sort of reframe it.
Thank you.
And it is consensus, so it's us and HS.
Yeah. It'd still be interesting to understand what it is about utilization, which would maybe help the predictions better.
And Stephanie, I think she can talk, she can say, okay, it was in this particular Medicaid eligibility group, it was in this.
Right,
Or she can dig deeper than.
yeah, that would be helpful. Okay, thank you.
The next area where we're having pressures is in the space of required rate adjustments. There's certain instances where we're either required by law or rule to pay higher rates that were not anticipated in the state fiscal year 26 budget. The first example is the DEVA Medicare Economic Index pay adjustment for FQHCs and RHCs. That's approximately a 2.7% increase. And also at Dale, they're seeing additional requests for extraordinary financial relief. And also the Vermont Veterans Home cost settlement is coming in higher than what was anticipated in state fiscal year 26.
So what was that again on the veterans home?
The gross amount is just shy of $1 million, and the general fund portion is about 370,000.
I think we're gonna hear from them on the bottom. The veterans side. We hear from them.
Later in the session.
Okay,
Lots of questions.
okay. We'll hear more. All right.
Okay. The next area is contractual agreements. And as Secretary said, this is where we had to negotiate contracts over the course of the year that resulted in higher costs. A lot of the first couple are in the IT space for Gainwell, the MMIS vendor at DEVA, as well as with Deloitte, who is the vendor responsible for our Medicaid data warehouse and analytics solution. There's also pressures in the transportation area for both DCF and DMH, seeing a small tick for increased costs or the rate, but more it's based on utilization. DMH travel nurses, that is also a pressure that Commissioner Hawes will speak about, as well as an uptick in forensic valuations. There's a $1.9 million request for the crisis stabilization program at a Wyndham facility. And then there's an increase for the WellPath healthcare contract. There's two components to that. One is to cover the average daily population increase. And And then the second part is for some costs that were incurred in state fiscal year 25 that we had to pay in state fiscal year 26.
I just asked while we're on here, the DCF and DMH transportation, does that include, is that the non-emergency medical transportation?
That's correct.
And so a contract has yet to be awarded on that, is that correct?
We have two vendors that supply transportation services. One is Youth Transit Authority. We've had a contract with them for a number of years, as well as the sheriffs. They also provide transportation.
Okay. Okay, so our public buses systems aren't part of that?
That's not part of this.
So
John?
Just real quick, and if we have to wait till later, that's fine here. On the travel nurse part of things, is that like a greater number of them or a greater cost that they identify for us to pay? Or is it 1%? A lot of hospitals have like kind of pushed back a little bit and say we're not going to pay that rate any longer.
I will defer to Commissioner Hawes when she comes in. She's up next.
You all set?
you know, the transportation, non-emergency, is that to transport prisoners to the hospitals? You mentioned the sheriff, so is that part of that? Or is this some other?
I don't believe, no, because that would be a DOC funded activity.
So, but sheriffs would be involved in transport from this?
I believe like for crisis stable, you know, when perhaps an individual is experiencing a crisis, they could be utilized.
Thank you.
Okay. All right, moving on to other operating pressures. The first item is the Pilgrim Park lease. As I'm sure most are aware of the return to office, and AHS needs to secure additional lease space to accommodate additional seats. So that is, that's going to be an annual cost of $433,000 gross. So DIVA is just asking for a portion of the general fund share and budget adjustment. We have the Planned Parenthood Medicaid backfill. So one of the conditions of HR 1 was a 1-year moratorium for Planned Parenthood to receive Medicaid reimbursement for claims. And so we are seeking approximately $1.1 million backfill. So because they are a critical provider that serves approximately about 16,000 patients, we felt it was necessary to backfill this with general funds for 1-year period. The DCF income verification system, there's a federal portal that we can no longer utilize to verify income. So DCF is procuring a new system to verify that. And then we have HOP shelter expansion investments. There are a few shelters that we've been funding with one-time dollars that we need to also ask for additional funding to cover those ongoing operating expenses.
How much is in that line item?
$2 million. And then DOC has a couple of utilities for water and sewer that they're requesting adjustment for, as well as staffing supports such as short turnaround stays at hotels and water and uniforms for those that are in the facility. We did have a few, as the secretary indicated, we had some savings and offsets. So for one, the utilization that we're seeing for the childless new adult group, that's funded at 90% federal reimbursement. So we are seeing an increased utilization for that Medicaid eligibility group. So that's approximately $4.8 million in general fund savings. We also had $4.6 million in general fund for that was carried forward from state fiscal year 25. And then also in DOC, there is a global commitment investment for community rehabilitative care where we draw down Medicaid investments for probation and parole officers. And we just recently implemented a new random moment time study. And the results are showing that we can claim more for global commitment investment. So that is savings for us.
Great, so less general fund, more.
Correct. Yes. Yes. It actually saves us $1.4 million. And then in the caseload space, the buy-in For DIVA, it is coming in less than was originally budgeted. And then DCF has other caseloads where they're seeing a decrease, particularly in the FSD and the ESD space.
What is a bias? Oh, I've never heard of that one.
Buy-in is where we pay a fee, Medicare Part B, is that right? Melanie? B or D? I think it's.
Do you want to pass, do you want to phone a friend or?
To know my consensus partner here. I believe it's, Diva will be able to speak more to it, but we have to pay invoices to the federal government for cost sharing on construction.
I'm gonna pass the buck to Steph now.
Okay, you're keeping a list, right?
Yeah.
It was.
Thank you.
You used an acronym for the DCF other caseloads. What are those acronyms?
Oh, I'm sorry. And the Family Support Division, Family Services Division, and the Economic Services Division. Okay, moving on to the one-time requests. We are requesting $385,000 in general fund for the fit up of Pilgrim Park. This is to purchase desks, chairs, conference room, technology and furniture, partitions and doors. We hope to also get federal funding. So the total estimated cost for the fit up is $765,000 gross, but the general fund portion is $385,000. The next one time is in DIVA. It's for Vermont Health Connect, $2.7 million general fund matched with $5 million federal fund. This is, so the vendor, right now they're transitioning. And so there needs to be upgrade for security and compliance in order to maintain connection to the federal data services hub. The Brattleboro Retreat bed day utilization. This was a budget adjustment one-time item last year as well. We have about 20,000 bed days budgeted in the contract for the Brattleboro Retreat, but we're seeing approximately 3,000 beds, additional beds higher than what we had budgeted. So it's a utilization adjustment.
Any explanation of, what's the increase, what's driving the increase?
I think DIVA and DMH would be able to answer that.
Thanks.
And lastly, the DCF Child Abuse Hotline. In order to maintain this hotline, there needs to be an upgrade to server requirements. So this is a one-time request for that.
Could we go back to the office fit up? You said that you're expecting to get some federal funds.
Yeah. Mhm. Yes.
How likely is that? And then what happens if you don't? You're just gonna have to pay it out of your own budget?
It's pretty likely. It's an administrative cost that we would be able to run through our cost allocation plan.
You're feeling pretty confident about it?
Yes.
Okay.
That concludes running through the slides. If we'd like to turn to the AHS ups and downs packet. Yeah, so you can refer to this throughout the AHS testimonies. It gives the line item descriptions and the various fund adjustments throughout budget adjustment. So beginning on page 3, that's where there's some minor adjustments for the secretary's office. Let's highlight. The first one is a net neutral adjustment where the secretary's office is going to earn more dollars in the SSBG, which is the Social Services Block Grant. And then we're giving the general fund to DMH and Dale instead. So those are just some net neutral adjustments. And then on the operating expense, you'll see this recurring adjustment. This is to transfer money for the ADS service level agreement. In 26, we budgeted an increase in the secretary's office, not knowing how it would be parsed out. And so these are just net neutral adjustments that you'll see within the agency.
So we'll see numbers going up in the
Correct.
other departments.
That is correct. And then the last item there is a $1.1 million request for ADS invoices that we were not able to pay out last year. And so we did carry forward money, but it was reverted and then requested this way. And that is to address the modernization upgrade of the automated call distribution center. That was about $1 million, and then some other timesheet billings that we were not able to pay before the end of the fiscal year.
So when you say you couldn't pay it before the end of the fiscal year, why was that?
As we come into close out, it's very, we manage across the agency where things will land, and we were seeing pressures in Diva, pressures in some other places. And so we just held off paying this one to see where we would finally land at closeout. And so by the time that happened, we hadn't paid these bills, but we did have identified carry forward after the fact. Okay, and then on to page 4, this is B301. So this is the big global commitment appropriation. Overall, it's $2.2 billion, all funds. So this is the mixing bowl to fund Medicaid. So where departments have increases in global commitment, you'll see offsetting increases or decreases in this appropriation to account for both the general fund match component and the federal fund match component. So in the first line item, this is the new adult change that I referenced earlier, where there's a savings of $4.8 million general fund, and we'll get $4.8 million federal fund in replacement. And then the other line items, again, these reflect all the increases and decreases of the global commitment changes throughout the department's ups and downs. There are a few offsets to note. So we had a little bit of carry forward for Medicaid consensus. That it was about $209,000. And then one other thing to highlight, and Diva can speak more to it, is the family planning rate increase that was appropriated in state fiscal year 26. Diva was not able to implement that as it was intended to draw down 90/10. And so we are making that adjustment here, and Diva can speak more to that.
They can speak more.
Yes.
We have a long Diva here.
And then a couple other down below Dale, there's a couple other carry forward amounts to that are statutorily required. Well, the first one is statutorily required for Choices for Care, where we're required to carry forward that for the program. And then we also the AFSCME. This is the collective bargaining unit that covers the independent care workers. Their bonus payment was paid out, I believe, in like the first or second week in July. So we had to carry forward funding for that. So overall, in global commitment, it's a $17 million general fund increase, which is about 2.4%.
What page are you on now?
I'm sorry, what?
What page are you on
Oh,
now?
that was on page 4.
422?
Yes.
Thank you.
The rest we're going to hear from the specific areas.
Yes. Yes. They'll get into the details.
Questions? Well, I'll ask a question. This is great to hear, and thank you for presenting this. This is the ups and downs. When we get to the budget, we're going to be looking for different things, and you have that information. And
Yes. We're testing out some different
great.
models or scenarios that we're going to run by the joint fiscal team to see if it meets the request. Yes.
Yeah, that's great. That's great. We're trying to move to something that's more meaningful for all of us, I think. And so I'm just when I see this, it makes me think about how little information we get this way, but I can understand it with the budget adjustment. We're changing something that we've already approved, but yeah, a new budget is very different. So,
Yeah.
So good. I'm glad you're aware of it. You're
Yes,
working on it.
we are
all
working
those
on it.
things, and,
We're excited with the new upgrade to adaptive, that we can track different reports to help aid in that, telling that story.
yeah.
Yeah.
Great. Well, we look forward to that. So anything else from the committee? Right. Thank you.
Thank you so much.
Thank you very much. Appreciate coming in and welcome to HAC. Was this your first time being here?
This role, yes.
Have you met everybody before?
I think so. Yeah, I served as the deputy previously,
Okay.
so I've always been in the audience
Yeah,
and
okay. All right.
available for questions.
We're getting back in shape. I'm getting back in shape.
Sure.
We have to introduce ourselves, so.
Thank you so much.
May I just one quick one, if I
Yeah,
may?
one quick question. Hope you're not.
I'm sorry, well, I didn't wanna, I'm
So
being
close.
asked by constituents, so if you could pull it together for me. What is the total cost of any leases related to the return to office? I understand the fit up,
Oh,
and I understand there's some movement with Diva moving out of the complex, out of the building into Pilgrim, but if somebody could just give me one little spot and say, here's what the cost is?
yeah, the net new cost annually will be 433 gross.
Okay,
Yes, for the new space.
And
That's
and
all.
the one thing to contemplate there is that, well, we've talked about it as a net new cost. This is a direct result of the sale of 108 Cherry Street. And so as we come in and we talk about the nuance of that, I think it's important for us to understand that the reason that we're needing to add additional space in Waterbury is because the building that the Department of Health was at in Burlington is a building that the state has put up for sale. And so that is a little bit different than needing new space for new space sake. It's replacing a space that we no longer have.
thank you.
Same kind of question. Of course, we toured Waterbury and there's a lot of empty space there at the time. So you're telling us that, with the people coming back to work as well as the people from Cherry Street, that you should have enough space at Waterbury.
Only with the addition of this other place, Waterbury, whose name I've been over. I was gonna say Pigeon, I knew that.
So you're not anticipating any big space need.
Any additional spacing beyond Pilgrim Park?
We need to wait and see what happens with the return to office. The 108 Cherry Street had 508 seats. The Pilgrim Park lease that we are engaging and entering in has 172. So we need to wait and determine what's going to happen in terms of exemptions, days of the week that people are in the office. Once we've established and settled that down, then we'll be able to answer that question with more specificity.
Thanks.
Thank you. Thank you both very much. Appreciate it. Feel better, Jenny. Okay, gonna move right along. Commissioner Hawes, did you bring friends?
I did. I always bring friends.
Yeah. Do you have enough chairs for all your friends?
Well, I just have one friend today.
Okay.
Who's retiring at the end of next week. So this will be a special trip for her today to give her the big hurrah send off.
Have a cookie. Those are retirement cookies. They don't count.
No calories, huh?
So welcome, and when you're ready, introduce yourselves, and I have some things here. Here we go.
All right. Good afternoon. My name is Emily Hawes, Commissioner for the Department of Mental Health. Thanks for having us today. Shannon?
Hello, I'm Shannon Thompson, the Financial Director for the Department of Mental Health. Nice to see you.
So we'll be continuing the discussion around the BAA. So first, I'd just like to reacclimate folks to the mental health system. And this is a grid of the different levels of care the Department of Mental Health oversees. From the lowest sort of outpatient approach, community mental health programs, that is our foundation blocks, to the overall system. And then up at the top is our highest levels of care, inpatient hospitalization for youth and adults. So currently at the inpatient level, DMH has a 25-bed facility for adults here in Berlin, the Vermont Psychiatric Care Hospital. We also contract with the Brattleboro Retreat for both youth and adults. And then we also have beds located within the Rutland Regional Medical Center that serve what's historically been referred to as level 1, but those individuals who require additional resources in order to meet their hospitalization stay. Then you'll see a step down is our secure residential, the River Valley therapeutic residence that is located in Essex. And then the next level down is our intensive residential and treatment programs for youth and adults, as well as a peer-run residential. There is a new resource coming online in the next few months, the Youth Psychiatric Residential Treatment Facility, otherwise known as a PRTF, that will be coming online at the Brattleboro Retreat here in the coming months. And then further down is our crisis supports and response. So things like our mental health urgent cares, 988, our mobile crisis response, crisis assessment, supports and referrals to different levels of care. That is across the age span, as well as our community mental health services, such as your traditional case management therapy. There are group homes in that system as well, and that's how we identify our base supports for the entire system.
So your new facility coming on board, how many beds or what's the capacity of that?
I believe that it is 12, but I can confirm that with you.
So how does that's the one at the Brattleboro Retreat?
Correct.
Right. There have been a number of failed attempts to have a replacement for Woodside. And, there's something in Newbury, there's something in Regents. Is this Brattleboro one, is that so what level would that one be at on this chart? Is that secure residential or?
What level is the Woodside replacement at?
Yes.
I'll let DCF speak to the Woodside replacement plans in progress, but when you think about a intensive residential program like the PRTF or the intensive residential programming for adults, those are individuals who need 24/7 care. Not as high as your nursing ratios for a hospital stay, but still need 24/7 care with medical and nursing oversight. The one thing that's not on here yet, but should be coming online, is the adolescent inpatient unit outside Southwestern Vermont Medical Center.
Yes.
Construction has not started on that, but we're in the final stages of starting construction for that. And that was a historical legislative act from last year.
So see, I'm just trying to get a handle on with the new things that you have coming online. How does that address the real capacity issue? Is it close? Is it 50%? Is it?
Love that question. It's a good one. So two things. The PRTF, currently the state of Vermont does not offer that level of care. And so youth are sent out of state to access that. So the PRTF will be our opportunity to bring youth back for that level of care. With the inpatient hospitalization, the only place to receive inpatient care for our youth in Vermont is at the Brattleboro Retreat. And so this, the SVMC project does a couple of things. It increases access, so there will be more available beds for youth. It also follows our goals of integrated care, so it is attached to a medical facility. And so some youth who have really complex medical and mental health needs, the Brattleboro Retreat is not an adequate facility to serve them. So this would allow an opportunity to have in-state access to that level of care. So with that, we can go into our ups and downs. I'm gonna turn it over to Shannon.
All right, you got a burner retirement.
Here's
One more time. One more time.
Okay. Does everybody have the ups and downs in front of you? Perfect.
And it's in the what section number you're talking?
314.
314. There it is. And 22 if people are using, I just want to orient people. Great.
Okay, so last year DMH split our budget into two separate appropriations. We have one appropriation for central office, and that encompasses the children, adults, and central office with all the crisis services. And then we have the inpatient, the facilities appropriation, which is Vermont Psychiatric Care Hospital and the therapeutic community residents. So we have two separate appropriations to talk about today. The first item is for transportation. There's been some increased cost for both youth and adults. So this is just representing the increased cost and a shift from Medicaid funds, to general fund.
So I know there was some questions in the previous testimony, but I can give a little more information around transportation. Tracy answered that correctly. We have two contracts, the YTA, Youth Transit, and then Sheriff's. And so we've seen a shift in historically, families, caregivers were able to provide transportation. We have seen the ability and availability of family to support transport to inpatient or discharge decrease. And so we have had to utilize our transportation contracts more often than we have historically. Additionally, individuals who are perhaps court ordered or are under the care and custody of the commissioner aren't always someone considered as having a severe mental illness. And so we need to be, we've had more of those requests for transports, and those need to come under our general fund.
So the transportation is to a facility.
Could be to a facility,
From a
could be
facility.
from a facility. We try not to do that as often as possible.
The discharge. fund.
Yes, it could also be, say somebody requires a trip to the dentist and is in involuntary care. We would use sometimes a sheriff to do that. Court transports, if somebody's at a hospital, they've been ordered, or in an emergency room, they've been ordered there by the court, we'll provide the transportation to the next level of care that's appropriate.
So how many rides are we talking about?
Ooh, we can get that for you. I don't know off the top of my head, but both of those folks.
It's a narrow thing that you're doing. And so I'm just wondering, how does the cost compare with the number of rides?
Yeah.
Yeah.
Along that line, and the sheriffs are being used for transport of, a troubled child that was been taken into custody.
Sometimes, yeah.
Facility, that sort of thing.
Mhm.
They're not being just used for It's a general contract to transport people.
Right.
Specific kind of people that are being transported.
Yes, if there's an elevated need for safety, but also if there's not transport available from, say, YTA, we also don't want somebody waiting in an emergency room unnecessarily. And so we're required to transport folks in the least restrictive manner. But we also want to get folks to their next level of care as soon as possible. And so there is a balance there. Those requests do come through the Department for Transport, and we arrange for those.
Dave, did you have a question?
Yes, thank you. I just wondered if somebody could help us, not necessarily now, but just what is the order of magnitude of the increase? Is it 2% increase or 15%? Could you provide that at some point?
From a dollar amount
Yeah.
or okay.
Mhm.
That is a really great question, and we'd like to get back to you on that.
Oh, sure. Thank you.
Mhm.
Okay, continue, please. Thank you.
The next item, forensic evaluations. This is again, cost increase for forensic evaluations, and it's also putting it all into general fund because a lot of the folks do not have serious mental illness.
So for some context, the Department of Mental Health operates as sort of a scheduler of these evaluations that are ordered by the court. So a court will decide whether or not a forensic evaluation should be ordered. And that is because the court is considering whether or not somebody is competent to stand trial. And so the number of competency evaluations has increased in Vermont, as well as the types of individuals that are being ordered for competency. And so we have seen an increase in individuals presenting with traumatic brain injury, with substance use, with other illnesses that are outside of a mental health condition.
Okay, all set?
Yep.
The next item, you'll probably see in everybody's budgets, it is an increase, it's a net neutral increase for DMH for ADS service level agreements. Federal revenue reconciliation. This is funding that was social services block grant funding to support residentials. And DMH is doing a lot of work with our residentials and crisis beds. And we have shifted that funding to general fund to help support those facilities covering costs that might not be Medicaid eligible. Such as room and board.
Okay, so it's not like you could get it federal funds, it's that what you're doing is not federal funds eligible.
We're working not to pass that cost on to the individual in the residential as well.
Yeah, and mostly it's with the residentials and crisis beds. So this is mostly to help cover those room and board costs in the crisis beds because it just doesn't feel right to charge room and board for somebody who's in a crisis. The next item is private non-medical institutions, PNMI. It is a caseload and utilization increase. It's $3.2 million.
Yes, so this is an increase as well in with utilization as well as a small rate. Those PNMIs have a small rate increase. And these facilities, private non-medical, so that speaks to the amount of medical and nursing oversight. It's a lower level of care than, say, a hospital or an intensive residential facility. And they treat children and adolescents with emotional and other challenges.
So you're finding more people,
Mhm.
that's the increased caseload and more utilization, so more need to same person, multiple trips or multiple issues or?
Yeah, potentially. Or increasing number of youth who need that level and require that level of care. These are also, correct me if I'm wrong, these are also in-state and out-of-state institutions. And so your out-of-state PNMI costs, we don't have as much control over those as we do our in-state. So it's a mixture of those varying elements that we don't have control over all of it, at least some of it.
So I asked before and they said I have to ask Diva, but this sounds like this part's yours about the utilization piece that's related to your work. What are you seeing are the drivers of that, or what do you sense is causing this?
Yeah, that's a great question, and I wish there was one single thing that we could point to. But actually, there's quite a few things that are impacting our youth today. And so you'll see that we've targeted a lot of services towards youth across the system. But namely that youth are presenting with significant mental health challenges and needing additional supports that are more than that can be provided in your typical outpatient setting. So they need more than one session a week or one session a month. They need a more intensive service delivery in order to recover, step down, and be productive back in their communities.
I think some of this is post-pandemic fallout. I mean, I guess you can't, it's anecdotal, but.
Yeah, it's hard to say. I mean, I think we've all been impacted by the pandemic in one way or another. We know that youth, missed, quite a bit of social interaction through school. We also know, like, I have a 4-year-old and an 8-year-old, and they spent years in masks. And so they interact with people a little bit differently at times. So we know that youth specifically are impacted by any major disruption, and COVID was certainly a major disruption for all of us. So
Mike, and then Dave, and then Marty.
Thanks for coming in. I don't need an answer now, but you'll be back.
yes.
Big budget. And I'm curious, after meeting with the Brattleboro Retreat folks, they said they had cut their use of travelers by over half. Significant savings. I'm just wondering, is the use of travelers in your facilities been high, and have you seen any decrease in that, or?
Yes. So the Vermont Psychiatric Care Hospital and River Valley Therapeutic Community residents both experience a high level of travelers. We are, from a hospital perspective, we have 3 less than we did last year. But that is still hovering around 47 travelers to fill vacant positions. And there are complexities to hiring hospital level of staff, specifically psychiatric hospital staff, and that it's a narrowing workforce. And we are a part of the broader state of Vermont collective bargaining agreement. And so we do work closely with our HR partners, hiring into range. There are some limits for internal candidates moving up through different positions. We're able to hire folks in, and retention is also just as big challenge as getting folks in. We have seen an increase in applicants. That's not going to impact this testimony, but I certainly hope that we're here next year with a very different story around travel partners. We're also working to decrease those contracts and bring them, continue to bring those contracts down.
Thanks.
Yeah, you're welcome.
Thank you. Dave, and then Marty.
Often when I'm out and about in my community, I hear from people who say, Dave, if we just had more community-based services, intensive family-based services, it's a lot better for these kids to serve them attached to their family with wraparound supports. And I said, okay, that makes sense, but if that were done at an earlier stage, could these be prevented? Or are these, as the PNMI, it's nothing you can do, they just got to go into a residential placement?
Well, I hesitate to say there's nothing we can do. There are always points along somebody's interaction with the system where perhaps we could have done better, or, something else could have maybe interrupted that trajectory towards the highest levels of care. And so you'll see that some of the work that we've put into this system with our mental health urgent care across the age span, 988. But the folks who are accessing those higher levels of care need that level of care. And so we want to make sure we have tools in the toolbox for everyone. Our goal, though, is that we're able to interact with folks as early as possible, because we know the long-term effects of, being in an institutional setting, whether that's a hospital or an intensive residential program. We don't want adults or youth to be accessing that level of care unless they.
Let me just follow up. Would a more robust Success Beyond 6 program change what we're seeing? Or is that pretty as good as we can get it?
This is going to sound very political, but nothing is as good as we can get it, right? And so each part of the state is very different. Some Success Beyond 6 programs are working really well because they have been able to hire and they're providing the services that the youth need in those schools. Others have vacancies, and that's a little bit more of a challenge. And then we're also seeing folks with private insurance needing access to care that folks are just as acute, have just as high of needs, but they're private insured. And so we are seeing some shifts in that population as well.
Complicated, isn't it? Thank you.
Yes, I wish it were not as complicated.
Yeah.
Humans are complicated. Already.
Yeah, I'm going back to this line where there's a 3.2 million increase in private non-medical PNMI.
Yes.
Is that both adults and youth, or is that both, or is that only youth?
It is youth and adolescents.
Adolescents, okay. And so then does that fit into the third level of your graph here where you have youth residential PNMI? That's
It does.
on this row here.
Yes, intensive residential and treatment programs. The green signifies youth-specific programs.
And is that the one that you said is not yet open?
No, those are open and operating. If you look to the far right where it says youth psychiatric, oh, thank you. Is that you there? Thank you. Oh, who did the arrow? Oh, it's helpful. Anyway, the PRTF is not on board yet.
Oh, that is the one.
At Brattleboro Retreat. And then the unit at SVMC is a hospital level. And so that's going to be up at the top level. And that's not online yet.
Okay, gotcha. All right, thank you.
Wayne, and then Lynn.
So 4 years ago, I was on the Economic Development Commerce Committee, and we were trying to provide grants and whatever to get more nurses. Are you seeing that being productive?
I think it did provide some initial supports for folks coming in. We partner very closely with all of the schools that offer nursing programs to give them a opportunity to come in to a facility like VPCH. Folks oftentimes picture it as something very different. And so we really try to get folks in there. But yes, those programs did have an initial impact. And we'll see over the long term how that really shifts. But we are seeing an increase in applicants.
Yeah, thank you. I'm just curious as to how the drug situation, the opiate crisis and all of the other drug-related issues work in with these, well, both adults and with young people. Is this part of your population that you're seeing, or?
So folks with substance use disorder the system is managed by the Vermont Department of Health. And so it is very likely that folks who are interacting with this system also have a co-occurring disorder, such as using opioids, or alcohol. For say hospital level of care, you're looking at that hospital level of care for someone's symptoms of mental illness, not necessarily that they need detox or something like that related to opioid use. But we do offer evidence-based substance use services across this continuum in a variety of different ways. Because we know that folks who are interacting with our system are also likely using substances. And we'll talk a little bit about, once the session gets going, about our efforts with certified community integrated health centers, which provides an opportunity for community members to access co-occurring care, substance use and mental health treatment without them having sort of to decide which door they're going in. Our goal is that a community member can arrive and we have a system that can serve them whatever their needs are, substance use or mental health. Ricky.
You have more for us? That,
Yeah, okay.
next one. 15.
All right. So now we're on to our mental health facilities appropriation. And this first line item is shifting funding from from general fund to Medicaid. We're actually able to bill down Medicaid for certain stays, and we just prior to this didn't have a good handle on. We didn't have good data on how much Medicaid would be able to pull in. So we're just moving this from general fund to Medicaid. Now that we've got our billing
What
stuff.
section or page are you on now?
Oh, I'm sorry.
315?
315.
Thank you.
Any questions? Moving on down. The next two items here kind of work together. It's really to right size our budget, put money in the right places. So we have the vacancy turnover savings. We've increased that, so it's a higher vacancy savings amount. And we have increased costs for travel nurses. And as Commissioner Hawes spoke earlier, it's not necessarily that we have more travel nurses. We just didn't have enough money in that budget line item.
So Tiff and then John.
Yeah, thanks a lot. I am, so first, if I'm remembering correctly, a couple of years ago, maybe even 3 years ago, you came in here with a visiting nurse price tag at budget adjustment of like almost $20 million. Yeah. So this seems to me like we're going in the right direction. I'm wondering though, what is the cost of the vacancy rate to the you know the institution? Because it's not just visiting nurses, right? It's
Yes, so as a whole, let's use VPCH as an example. About this time a year ago, they were at 43% vacancy. And so that's primarily your 24/7 positions. Those are your positions that are on the floor. Your nurses and your mental health specialists. Now VPCH is at a 39% vacancy. So we are in a year, we have seen that shift. When you are running a facility that has a high number of travelers and permanent staff, but it's off balance, you do run the risk of some impacts with morale. It is not lost on permanent staff that a travel contract is getting more money and more flexibility at times. But it also has the potential to impact the safety of the facility. And we are always striking that balance of too many travelers and not enough permanent staff where we have the ongoing, institutional knowledge and training. We train everybody is well trained, but there's a risk when your balance is out of whack with with your travel contracts and permanent staff. And so that's that's one of the real impacts is the care that folks are potentially receiving. People get good care there, but the laws in Vermont are very different than other states' statutes. And so it takes a period of an adjustment time for folks to come in.
Are there other areas where you are not hiring or not able to hire?
There are no areas outside of nursing and our mental health specialists that we are not able to hire. We have a full psychology team. We have a full social work team. We have a full recovery services team, full kitchen, full admissions staff, full staffing office, all of predominantly all of the other ancillary departments are full.
Same question, just a little bit different. How many people are you deficit?
Ooh, we can get that for you. And that would be a point in time. People are coming and going all the time, but I'm happy to provide that. Hi,
Good to see you again.
good to see you.
Thanks for coming in. So I kind of have a question about the traveling nurse and the cost of that. Because
Yeah.
I just finished serving a 6-year term as a trustee on our board of directors for our local hospital chair for a couple of years. So it was just a time period. We needed to hire a lot more traveling nurses to fill the void and
Yes,
paid what they were charging here us. And we've dropped ours,
yeah,
just through, more permanent, fulfillment of open nursing positions. That's been great here for us. So just to get myself up to speed on kind of where you've been here with us, with the cost of that, do they define the cost to you or do you define like what you need?
sure.
And it's an interesting question here.
It is, yes.
We've had such big reliance and we still do. So, criticism against hiring traveling nurses, we have to.
Yes, I'd love a day when we don't have travel nurses. I think we would all want that. So we do negotiate those contracts. And we are seeing that negotiation power shift. So during COVID, right after COVID, that negotiation strength really sat with the travel companies. And so as healthcare starts to rebound a little bit, that's shifting and we have and we're renegotiating those contracts now.
That's been a successful process.
It has been so far. It'll be, I think, our third attempt at, our third sort of shift down.
Here.
Yeah.
Thank you.
You're welcome.
Okay. Okay. Next line item is.
We have one other line item, and that is funds to cover the cost of room and board. Again, it's not necessarily an increase, it's just shifting from Medicaid to general fund to cover those costs.
So it's just not authorized, it's not what they authorized. Medicaid.
Yes.
Medicaid will not cover room and board costs.
Okay. Great. Any questions for,
Just.
Go ahead, Mike.
Back on that same question, how many people are deficit? Give you an idea of what the average cost is. I know with overhead and everything else that goes into it, like, say a $75,000 employee that's making that is probably 150 or close to 150,000 total. You got any idea of what it might average?
I don't, but I would imagine our HR partners have a lot of that information. Yeah.
okay, I'm not seeing any more questions.
Okay. Well,
Thank you so much.
Appreciate it.
I guess I do have one more question for you, and that's what I've asked before. You guys are getting set for your budget presentation and you have our agency letter and you kind of know what's going on and you can phone friends over here if you need them. And so all set on that.
Yes, thank you.
Perfect. We look forward to hearing it.
Yeah, thank you. Okay.
Thank you.
Thank you.
Yes. Thank you for your service.
Yeah.
Thank you.
Selfishly.
Retirement, do you have plans for January?
Oh, yeah, we're all alone.
Have a blast.
Great. We've been recruiting for 6 months.
Enjoy, well deserved.
Yeah.
So committee, we are gonna take a 7-minute break.